Hello everyone, my name is Christy Thomas and I am completing my coursework at A.T. Still University. My applied research project is clinical presentation of sport-related knee injuries at the point of care. And this is a report from the Athletic Training Practice-Based Research Network. I'd like to extend a big thank you to Dr. Lamb and Dr. Ashley Marshall for all of their advice, their feedback, and their mentorship with this process. So, a little bit of background information. The knee joint has one of the highest rates of sports-related trauma after the ankle, but it does account for the highest percentage of severe injuries associated with time lost from participation that is greater than 3 weeks. So, specifically, ligament sprains, meniscus tears, contusions, and knee pain are the most commonly reported diagnoses, which can lead to functional deficits, the time lost that we mentioned previously, as well as increase in financial costs. In the long term, these knee injuries can then lead to a decrease in health-related quality of life. So the CATIE, or the Commission of Accreditation for Athletic Training Education, requires that students have formal exposure and can demonstrate a comprehensive musculoskeletal evaluation process. However, few data are available regarding steps that athletic trainers take when they are completing a routine assessment. So a study by Lamb et al. Observed that most athletic trainers are commonly using the same set of special tests regardless of the suspected injury. But there is a knowledge gap regarding what other aspects of the evaluation process are being used, such as pain assessment, range of motion analysis, strength testing, and neurological examinations. So a thorough clinical examination should be completed in order to help improve the accuracy of the clinical diagnosis, and it should include all components. However, one systematic review suggested that many recommended evaluation elements were lacking during the orthopedic physical examination. In order to ensure that these injuries are diagnosed and managed properly, it's then vital to have a comprehensive assessment of the injury. Furthermore, the systematic process can decrease healthcare costs, time loss, as well as increase clinician efficiency. So currently there's limited evidence and data that details the processes that athletic trainers are utilizing when evaluating sports-related knee injuries. Therefore, the purpose of this study was twofold. First, we wanted to identify what evaluation strategies athletic trainers are using when completing a patient assessment, and then second, to describe the differences in clinical presentation between common knee injury diagnoses. So participants included 203 athletic trainers that were practicing at the clinical practice sites associated with the Athletic Training Practice-Based Research Network. The majority of the athletic trainers were female at 64.5%, and they had been certified for an average of 4 years. So this study is considered a retrospective analysis of the de-identified patient records. All patient records were created by participating athletic trainers using an electronic medical record system. The ICD-9 codes were used to identify knee injury documentation, and patient demographic forms and injury evaluation forms were then pulled and analyzed. So on here, you can see the breakdown of what characteristics were found on the demographic form, as well as the characteristics that were found on the injury evaluation form. Our analysis involved calculating summary statistics such as the frequency, the percentage, the mean, and the standard deviation. All of our data was analyzed using the SPSS statistics software program. All right, so if we look at some of the results, we can see on the table to the left the breakdown of knee injuries by sport. Overall, a total of 1,022 sport-related knee injuries were evaluated, and football, soccer, and basketball ranked with the highest frequencies. Non-contact mechanisms of injury were most common at 43.5%, and this was followed by contact mechanisms, which comprised 34.5% of all injuries that were reported. Similar to data provided in the background information, our study supported some of the most common diagnoses, with ours including cruciate ligament sprains, knee pain, and MCL sprains in our top 3. When we review the evaluation characteristics, we find that the average pain levels upon examination were a 5.1. Effusion was most common in internal derangement, cruciate ligament sprains, and MCL sprains, while edema was most frequently documented in bursitis, patellar subluxations, dislocations, as well as cruciate ligament sprains. Ecchymosis overall was not very commonly found, but it did present most commonly with contusions, internal derangement, and chronic meniscus tears. And then range of motion deficits were most frequent with internal derangement, cruciate ligament sprains, and patellar subluxations and dislocations. Finally, with the physical assessment, this study found that palpation was by far the most frequently documented component at 94.5% of the time. Manual muscle or strength testing was utilized about a third of the time, while the neurological evaluations and flexibility testing were incorporated 23.8% and 17.2% of the time, respectively. So, overall, the presentation of knee injuries tended to be similar in those that resulted in greater time loss. So, for example, greater time loss injuries had limited range of motion and displayed effusion or edema. These signs of effusion or edema may also then affect the inclusion and the reliability of manual muscle testing and flexibility assessments. So we hypothesized that the range of motion deficits could be related to swelling, as injuries that had higher amounts of effusion or edema also exhibited a loss of range of motion. So we found that athletic trainers utilize palpation in nearly all of their assessments. However, the other components of the physical examination were used less frequently. Overall, a lack of complete examination may limit the clinician's ability to effectively formulate a differential diagnosis. So it's important that athletic trainers are using all portions of the examination process. In order to determine what's considered normal, flexibility testing, strength or manual muscle testing, and neurological testing should be performed bilaterally. So the ability to discern patterns within the clinical presentation can make the evaluation process more efficient for the clinician. Clinical clusters and clinical prediction rules may be useful for athletic trainers to assist with the assessment of the knee injuries. So as mentioned, athletic trainers should consider all these components of the physical exam process, because there are times when the clinical evaluation may actually be more accurate than the diagnostic testing regarding knee injury recognition. So some limitations for this study included the reliability of the participants regarding the accuracy of their documentation and the dependence on their ability to complete the injury evaluation and demographic forms. Additionally, while this study assesses the clinical evaluation process, we cannot accurately assess the aspects of clinical reasoning. So overall, the majority of sports-related knee injuries occurred in season and were most commonly caused by non-contact mechanism of injuries. Sprained cruciate ligaments, MCLs, and contusions demonstrated the most overall signs related to observation and inspection. And then palpation was the most commonly utilized examination component within the physical examination process. Here are the references that were used in this study and presentation. And thank you very much for your time.